Picture this. You're just going about your normal day, fully counting on your parasympathetic nervous system to do its simple job to just rest and digest. But then, seemingly out of nowhere, bam! You are thrown into an absolute gastrointestinal nightmare. The intense cramping, the total unpredictability, the sheer discomfort, it is absolutely miserable.
Welcome to The Explainer. I am so incredibly glad you're here at The Confused Neuron. Today, we are virtually grabbing our whiteboard markers and slicing right through the pharmacology of irritable bowel syndrome. We're going to find out exactly how to make these complex pathways simple, pick up some high-yield facts, and hopefully share a laugh along the way. Let's conquer this gut chaos together.
So let's dive right into what this condition actually is. Irritable bowel syndrome, or IBS, is characterized by chronic abdominal pain and totally altered bowel habits. But here is the absolute kicker. The thing you have to remember, this happens in the complete absence of an organic cause. You could run all the scopes, order all the CT scans, and draw all the labs you want, but you are not going to find a structural abnormality or a neat little bacterial infection. And honestly, that is exactly why IBS is so notoriously tricky to pin down and treat.
Now, what's really fascinating is the foundation this sets before a prescription pad is even touched. Because there's no glaring organic cause, it just doesn't make sense to immediately blast the patient's receptors with drugs, right? Diet modifications are your crucial first step. Psychosocial modifications also play a massive role here, because the gut-brain axis is a very real, incredibly powerful two-way street. And hey, it's super important we don't confuse this with inflammatory bowel disease, or IBD, like Crohn's or ulcerative colitis. IBS simply does not have that same inflammatory destruction going on.
When we finally do need to treat this pharmacologically, the disease essentially bifurcates into two main camps: IBS-C, which is constipation predominant, and IBS-D, which is diarrhea predominant. Our entire pharmacotherapeutic approach is completely dictated by one simple question: is the gut moving too slow, or is it moving too fast?
Let's crack open the arsenal for IBS-C first. If the GI tract is totally backed up and motility is sluggish, how do we get things moving again? We actually have a couple of heavy hitters for this. First up is Linaclotide. Its mechanism of action is super clever. It increases intestinal fluid secretion by increasing cyclic GMP. It basically floods the lumen with fluid to wash everything out. Now, as you can probably guess, the side effects include diarrhea, flatulence, and abdominal distension because, well, sometimes it works a little too well. Then we have Lubiprostone. This one is a chloride channel activator. By actively pumping chloride into the intestinal lumen, sodium and water naturally follow it. This enhances a chloride-rich fluid secretion to essentially lube up the digestive tract. Common side effects here are nausea, vomiting, and headache. Want an easy mnemonic to remember this? Linaclotide uses liquid, and Lubiprostone lubes with chloride.
But hold on, there is a massive red flag you absolutely need to watch out for with these medications, specifically centered around the number 17. Linaclotide has a strict, absolute contraindication. You must never, ever use it in children under 17 years old. It's a highly testable fact and a critical safety warning you want to lock into your memory right now.
It's also pretty wild to see just how specific these drugs can get. Lubiprostone, for instance, is actually specifically indicated for women with IBS-C. And to combat that pesky nausea we just talked about, it has to be taken with food. If your patient takes it on an empty stomach, they are going to feel absolutely awful. And honestly, they'll probably just stop taking the pill altogether. So, take it with a meal, decrease the nausea, simple.
Okay, let's completely flip the script. The gut is moving way too fast, it's totally hyperactive, and it is time to shut it down. Let's attack the IBS-D, diarrhea predominant side of things.
Let's do a rapid fire through the mechanisms. First up is Allosetron. This is a 5-HT3, or serotonin antagonist. By blocking serotonin in the gut, we slow things right down. The expected side effect? You guessed it, constipation. Next is Alloxadoline. This is a mu-opioid receptor agonist. Think about how systemic opioids cause constipation as a side effect. We're basically using that exact mechanism intentionally here in the gut to slam the brakes on diarrhea. Finally, we have Rifaximin. This is a structural analog of rifampin that decreases the bacterial load in the gut, which can be highly effective for short-term use in IBS-D.
Do not get too comfortable, though, because we really have to look at the red flags. These medications pack a serious punch. Alosetron is restricted only to women with severe IBS-D, and it carries a rare but absolute nightmare risk of ischemic colitis. Luxatiline carries a rare risk of pancreatitis. Plus, because it directly hits opioid receptors, there is a real potential for dependence and overdose. And Rifaximin, well, because it's essentially structurally blasting the gut flora, it's for short-term use only, and you run the risk of a Clostridium difficile infection. In other words, you solve the IBS diarrhea, but you might unlock a much, much worse type of diarrhea. You really have to respect these meds.
Now, what if the main problem isn't just the speed of the transit, but the fact that the gut is having intense, agonizing spasms? Whether you're dealing with the IBS-C camp or the IBS-D camp, cramping hurts. Enter our bridge medications, the antispasmodics.
It turns out our antispasmodic arsenal relies heavily on two main drugs, dicyclamine and hyoscyamine. Their mechanism of action is antimuscarinic. Remember earlier when we talked about the parasympathetic nervous system being the rest and digest system? Well, these drugs go in and forcefully block those muscarinic receptors. By inhibiting that parasympathetic drive, they dynamically decrease GI spasms and motility, providing some serious, much-needed relief from the cramping.
But of course, as they always say in medicine, there are no perfect solutions, only trade-offs. When you block those muscarinic receptors, you pay the anticholinergic toll. You might remember the classic medical joke, dry as a bone, blind as a bat, mad as a hatter. Patients can easily experience drowsiness and dry mouth. And critically, if you overdose a patient on hyoscyamine, you risk some incredibly wild side effects, like literal hallucinations, life-threatening arrhythmias, and severe nausea and vomiting. So dosing these carefully is absolutely paramount.
So, let's tie this entire whiteboard together into the confused neuron treatment algorithm. The logic here is actually beautiful. Step 1, you always start with diet and psychosocial modifications. Step 2, classify the enemy. Are we dealing with IBS-C or IBS-D? Step 3, deploy your targeted mechanism of action. Give those fluid secretors for constipation or those gut-slowing agents for diarrhea. And step 4, if severe crampy pain is present, add in those antimuscarinic antispasmodics. It is a wonderfully simple, logical flow that locks the pathophysiology right into place.
When you break pharmacology down logically like this, it's amazing how much it really revolves around just manipulating the body's natural pace. But honestly, it leaves you wondering, if the gut-brain axis is powerful enough to cause such severe physical symptoms without any organic disease, what other conditions are we currently treating with pills when the root cause might just lie in the mind? Keep exploring, keep questioning, and we'll see you next time on The Explainer.